can talk about their sexual function after a diagnosis and treatment of prostate cancer. Are there ways to preserve sexual function or improve it after a prostate cancer treatment?
Sure. So I think loss of sexual function really does often depend on the choice of therapy that's chosen. So we know that the prostate has plenty of nerves. We know the location it is right behind the penis. And so when you're having surgery, you're going to mess with some of that nerve intervention. So part of the loss of sexual function is not the same for every individual. It truly is based on what other meds are that patient on, what other medical conditions does that person have, and then the treatment in and of itself that was chosen and the effect of that. I think there's a couple of things. Are there treatments? There are absolutely treatments. The other thing that we also have to know is that erectile dysfunction doesn't last forever as it relates to the prostate therapy. It just like incontinence wanes over time as the therapy improves in many cases. So one of the things that I continue to hear Marvin say is what we see today is not what we have tomorrow. You've got to give yourself grace as you're going through that. Your partner has to give yourself grace because we're going to affect it. Hopefully there's some oral, maybe the blue pill, maybe Cialis, maybe some of the other medications are out there. Maybe the vacuum pump may be the option. Try the other options once you're healed, and that's an option. And then give yourself grace and time between you and your partner as you heal through the process. But also realize that it may be a reality. And that is where I think a lot of the mental health pieces come in. But you've got to be vocal. Man, you have to speak up and talk. You have to discuss this.
And that's absolutely true. Because it affects your partner as well as you. You have to give grace, and your partner has to give grace, wanting you to be better, because she wants you to return to some semblance of what your baseline was prior to. And so communication has to be there. So you want to rush back there, she wants you to rush back there, but neither one of you may be mentally ready to get back there. So it takes time. So you know, the elephant and so for one of my cousins, he had surgery, and so part of his physical therapy was daily Cialis, and it was not necessarily for sexual function. It was more to promote blood flow during the healing process, and so that's something to remember. And so that typically is something you do with surgery. It was offered to me not for necessary sexual function, but for blood flow. I said, yeah, doc. That's a diagnosis, well, whatever. Okay. He said, it's okay, bro. Look, he said it promotes blood flow and protects length. I said, say what? You heard me say protect. I said, I'll take 2, please. Since we're being real here, that's just the reality.
The reality of it.
That's just reality.
So we've all heard a lot of great discussion on this panel, but we still know that there is a lack of Black men being screened for prostate cancer. Dr. Meyer, why do you think that is?
There are definitely some obvious reasons, and there's no one reason. I think there's a couple of reasons. Number one, the elephant in the room, as we talked about, is men fear that rectal exam. That's the number one reason. I have done a lot of community events and screenings and health fairs and asking men why haven't they gone, and they fear this finger. And as I mentioned, this finger is not bigger than anybody in this room. It's a 10-second exam, and it can save your life. Nobody wants to have it done. I don't want to have mine done, but I have to get mine too, just like I'm doing it to my patients to protect them. I have to protect myself. Sure. But the fear of the rectal exam is in our community. I listen in the barbershops when I used to go take my son, just sitting there listening to conversation. That is the one thing that's keeping men away, and it's because they don't have any awareness. They're just hearing what their friend says. Or, you know, you're not going to turn me into nothing. You know, it's lack of knowledge. And today we got educated on knowledge. We understand what the prostate is, what it does, why it's important, and why we have to do that exam, because there's no other way to get to it, all right? The second reason is men typically are macho, egotistical, and understanding I have to be tough. And if I'm having some urinary symptoms, or I'm having concerns, and I have to go get that exam, I can deal with this on my own. I don't need to go to the doctor. Another issue is access to care, right? I mean, sometimes that is also an issue. So we have a lot of different reasons why men don't typically get screened. There's no one reason, but education is key. And I will tell you, the most powerful thing is not coming from me or another physician telling you to need to screen. It's coming from each one of you. A family member will listen to you much more than they will listen to me. If Marvin is talking to his family and friends saying, look, y'all need to go get screened. This is what happened to me. They're more likely to do it because they trust and believe in Marvin. I'm their physician and they may trust me, but I may just be their doctor. So sometimes coming from a loved one is the most important vessel of communication to encourage people you know to get out, go get screened, and go get checked. And I'll stop there.
Thank you. Dr. Junior, same question for you. What are some possible reasons that black men are less likely to be screened in your practice that you've heard or understood?
I think many times men have a tendency to put things off. I don't need to know, I'm gonna be all right. And they fail to follow through on personal issues. People come into the office, Doc, can I get some, look. Okay, so you haven't even been diagnosed with a prostate disease, but you're coming in with ED. But your diabetes, your A1C is 14. Well, what is this? First time coming into the clinic, and I want some blue pills, and your A1C is 15. Have you ever thought diabetes is the cause? They want to keep the function, but not willing to do what it is to keep the function. Take care of the body. We fail to yield to that. And then again, access is there. But also the knowledge, really. We're training disciples. Go out to all the world and let people know. That's right. This, dude, you're going to have problems. But it's okay. How many of you all walking around and don't know how much money in your bank account? Awareness. Awareness. Be aware. You know what? It's just, it ain't working quite right. What's going on? And try to find out what's going on. Don't just get a Band-Aid, the blue pill. It covers something. I give you some medicine for pain, but especially in the abdomen, you do not give people a lot of pain medicine when they're in pain in the belly. Why? Because your intestines are there, your liver's there, your gallbladder's there, your pancreas there, your spleen is there. You got so many different organs, I don't know where it's coming from. And guess what? That pain will drive you to get help. Don't cover it up. Unearth it. Get to the root. And we fail to get to the root because I can take a Band-Aid.
That's good.
And to follow up what Dr. Myers said, you trust the loved one, what Keith said also, is that even me, myself, I don't want to talk about it, but somehow I've morphed into this. And so the one thing, and I shared it with my coworkers, and a lot of times women reach out to me about their men. This is what's going on. Can you talk to them? Blah, blah, blah. And so just being able to talk about it freely with each other is the way we get us into the doctor's office. So it's definitely real.
Excellent. And I like to share too. So sometimes this sounds like a no-brainer. But we also know that there are social determinants of health that will keep you from getting the help that you need. Some of those things are lack of insurance or no insurance at all. Find clinics like Matthew Walker that will work with you on the sliding scale. Other things are transportation. We talked about your cars and getting your tires rotated and whatever you have to do. Or call a loved one. Or find out what transportation services are offered in your community. There are several things that are those social determinants of health that may keep you from getting to that doctor to make sure that you're getting the help that you need. There are political determinants of health. We know what our political environment is like now. And specifically because this is a diagnosis that is more likely in African American men to be a comorbidity and take your life, we want to make sure that you're reaching out and talking about these things with your resources. So what I've taken from our conversation is you need to show an interest in your loved ones, have those conversations, talk with them about prostate cancer and what they can do. If you need to, go to the doctor with them, pick them up, sit in the waiting room, and be ready to encourage them after they've completed that test with the finger or the blood. The best way to learn about your health and make treatment decisions is to make sure you get all of the information that you need. And of course, your mental health plays a big role in how you manage these things. So make sure you talk to a specialist about your mental health and your anxiety or worries about a cancer diagnosis. At this time, we'd like to take questions from the audience. We have a couple of mics.
We got a couple of mics. Can I get some brothers to come administer the mics to the audience? You know, there were a lot of things we learned today. Me personally, I've learned a great deal. But most importantly, we have to learn to be open and share what's going on with us. And this is an opportunity for you to ask those questions, and you're in a very controlled environment with experts. Got a question back there, Brother Dane.
My name is Damon. My question is to the panel. Is there any information in regard to men with vasectomies or without vasectomies that affects prostate or prostate cancer, the diagnosis?
Yeah, at this time, and I say at this time because research is always developing, but there's no known association with men who have a vasectomy as having a higher risk for prostate cancer. So the answer is no. So you can have a vasectomy that doesn't put you at high risk. A vasectomy is only basically cutting off the opportunity for sperm to travel and get into the urethra, which is away from the prostate gland.
Doctor, several years ago, I was in a similar situation as we are here, with doctors talking to an audience, and a urologist said that testosterone is the friend of prostate cancer. I had a gentleman on my podcast Thursday who sort of said only if it is a hormone-based version of prostate cancer. I'm not sure how that fits, but in your treatment, is testosterone therapy one of the things that you advocate or something you stay away from?
That's a very good question, and in general, the answer is you stay away from testosterone. Testosterone feeds the prostate tissue. It will make it grow larger, it will make it grow faster, and when the prostate grows, it puts out more cells in the bloodstream, right? So if you think you already have, or if you know you already have prostate cancer, stimulating the prostate gland will expedite and make that cancer spread and actually become more rapid. So if anyone is on testosterone, we actually have to, number one, monitor your PSA regularly to make sure that your PSA is not going up from the testosterone. And if you think about the treatment for prostate cancer, especially for advanced disease, it's basically knocking out all of your testosterone in your body. That is one of the treatments when we were referring to androgen deprivation therapy or anti-hormonal or hormonal therapy. The goal is to get rid of testosterone so it does not stimulate the prostate. So to summarize, the answer to the question is avoid testosterone if you have prostate cancer because it can make it worse.
So let me do a follow-up on his question. So what if there's some, some of us may be born with higher testosterone levels, as we call them macho guys, so to speak. Would that be a contributing factor for them maybe increasing their chance to develop prostate cancer?
It's a good question. That's when we don't have science, evidence, or research on to know about natural hormone levels and the association, if that increases the risk of prostate cancer. But typically, as men get older, your testosterone level declines. So with every decade of life, your testosterone is actually going down. You peak your testosterone in your early 20s, mid-20s, and then every decade after that it goes down. And so as prostate cancer risk goes up with age, testosterone is actually going down. So we don't really have hard evidence to know what someone's natural testosterone levels are, because really they're going down most times by the time you're getting diagnosed with prostate cancer. But that's a very good question. One for research, actually.
Just a question in general along the lines of physician care and African American men going to doctors. Are we seeing that post-COVID? Are we seeing our numbers even going to the doctor increasing? Or is it leveling off, or is it worse than where it was? Whatever baseline to use, I said post-COVID, but it could be 2020 moving forward. Are we going to the doctor for anything?
I would say yes in general. I don't think, and Dr. Junior can never say, but I will say awareness, education, social media, commercials, the things that we didn't have when I was a little boy to get the news out to the public. We have those venues now, right? I mean, you think about things like TikTok just being very powerful. A 30-second segment sometimes influences somebody. Not that we're being influenced as the people in this audience, but just the power of influence from social media, awareness, commercials, things of that nature. So I do think men in general are going to the doctor much more than they did 25 years ago. But I don't know, I can't tell you exactly what those numbers are. I don't know if Dr. Junior have any comment on that.
I think that the numbers pretty much in Matthew Walker, and again, we see people with insurance, without insurance, and we still try to provide most services. And when it's time we have to move people out, we do. But the numbers are about the same. But the thing is, it's still under. It's still under. I ain't gotta go. I'm good. I'm good. And I wonder, why am I 1 and 8 gone? These are educated people. And I try to make sure, because hey, 5 years ago I just had a kidney stone, and the one kidney I got, septic, in renal failure. So the thing is, I want to live. We have to choose that. But other people, the social determinants, the mental health issues that I can't. Yes, you can. And we say things, then do it. So the numbers are still about the same, but it's still under.
And I may add to that, I actually was sitting in a meeting on Wednesday, and our utilization data showed during COVID, we saw more patients than we are seeing today. Now, again, maybe because people were more isolated, and maybe because they were not going into the office, they had the opportunity to come to the doctor. We also service a great deal of a Hispanic population. We're seeing fewer numbers because ICE is on the street. And so it's gonna depend on what's happening in our world, if it's social determinants or political determinants sometimes.
Dr. Jackson, I have a question based on the subject you're talking about. Is there some kind of I'm gonna use this term, Jedi mind trick that we need to start using on our brothers to get them to understand how important it is they do see a physician? Is there maybe some kind of, psychological application that we can use when we speaking to each other, or those we know need to go to the doctor, to maybe get them to go to the doctor?
Keep taking them to funerals.
You say, hey, that's
You will make my job so much easier. So I like psychological education. So the more I share with you about how to educate you on certain subjects, including your fear and your anxiety and your depression and what that looks like and how it's affecting your life, that should give you enough information to want to make a movement. So psychoeducation is very important. Taking them to funerals may help, but it may not. It may just make you sad or sadder than you were. Dr. Reynolds Burns has a comment.
I'd also like to add that access doesn't equal better outcomes. And so just going is important, but we need better outcomes. And one of the things that we need is an environment where black men and women feel respected and heard. Matthew Walker may be one of the few, because people will not continue to go to appointments where they don't feel respected, heard, and cared about. And so I believe in each one, teach one. If you're in an environment and you have a physician that you felt respected, heard, and cared for, then you got to get the word out and say, you know, if someone tells you, well, I went to my doctor, I didn't, you know, from a pharmacist perspective, we often hear patients say, can you tell me what this is for? I went to the doctor and they gave me a prescription and I don't even know what I'm taking it for. Okay, then it's time for you to transition. Find somebody that's explaining, helping you make decisions. So access and going is one thing. What we want you to do is access, and then it's almost like going to church. We want you to go in, but we want you to come out with something. You got to find providers. We have to find providers. And studies have shown people do better with providers that look like them. That even in and of itself is under attack right now in America. We're seeing less and less opportunities. And so our outcomes may be worse as we go through this process. So when you find people that look like you, that care about you, that educate you, then it's time for you to, you know, tell somebody else and bring them along with you. Because that's one of the reasons we don't go. We're just not, I don't want to deal with that. I don't want to go back into that office again.
May I?
yes.
Desperately in need, and for some reason don't seem to want to make the trip to Matthew Walker when it sits right in the middle of the community. They don't want to come, they don't come to Meharry for assistance. Pardon the personal reference, but we're having a health fair next Saturday on Knowles Street. Last year we had a nice crowd, but not what we thought we should have as it amounts to, as it relates to people looking for assistance. And I think it is a matter of access and feeling comfortable in that access. And as we talk to people, we find that is a problem. There's so many different reasons not to. The police may be there. There's somebody watching, et cetera, et cetera, et cetera. And that is difficult to overcome. Dr. Jackson, you talk of depression, anxiety, suicidal thoughts and ideations. When you look at the numbers that you gave today for prostate cancer, how do they stack up against the numbers for other forms of cancer?
So I don't have the answer for that. And so I am one to research if it's something I don't know. So I appreciate you bringing that to my attention. But I do want to talk about access to Matthew Walker. I have patients, I've been there going on 9 years. I have some of the same patients from 9 years ago. Sometimes people don't know what they don't know. And once they come in and speak with someone like myself or Dr. Junior or some of our other experts, they get a clearer understanding of how much we care about our community. We have a model that we call an integrated model. People don't have to seek me out separately as a psychologist because I'm in the clinic. And when Dr. Junior sees his patients, I go directly into the clinic room and speak with that person. If they're having anxiety, depression, grief, organizational problems, school anxiety, whatever that is, and get them on my schedule. Each and every time a person comes in our office, they are assessed for depression and suicidal ideation. That drives my staff and myself to go in to speak with that patient and get the lay of the land and get them out for coping strategies and to help them. And so I think it's unfortunate that people are living in 37208 and we have such a gem and a great number of services to offer. So we hope that changes. But until then, we're gonna service all the people we possibly can that are really excited about getting the health care they need.
Doc, I have a point on that because when I had renal cell carcinoma, and Dr. Hamburg was my urologist, and Dr. Hardy, and all the guys up on the round building. Part of it is that sometimes people don't want to come because somebody know you. Oh, Dr. Junior, TW used to be the dermatologist. Oh, he got a skin problem, or she got a skin problem, or they, you know. So sometimes people, because Marvin has said something about being a private person, and these are personal issues, it's none of your business. I get it. But after a while, you come to understand, it is what it is. I got this problem. And that also helps other people. You know what? I can step up there too. Rather than, they know I'm here. You know, I'm going to be like a movie star and put some glasses on and try to, I'm going to be me. And we have to understand, you need the care. Go where you can. And eventually, you'll find the ones that are out there for you if you can go someplace. I mean, right now, because what's comfortable for me is go to Hendersonville for my urology and all this stuff, because Hendersonville Hospital, hey, when I got sick and had that kidney stone 5 years ago, that's where I went. I couldn't make it back into Nashville. And so you have to find that. All these things, access to it and how we get to it and who gonna see, they don't know who I am. I don't know, but if I come here, they do know. But I do go here for my internal. That's because I'm supporting my home institution, and, you know, I don't care if you see me.
And then on top of that,
We have a question.
okay.
Israel.
Yeah, I want to thank the panelists for taking the time and sharing this valuable information. My question, I think you touched on it, is about insurance. It's the other side of the coin in terms of access. Insurance companies are making record profits and they're increasing premiums, and they're also denying care. So when you're looking at oncology-related services, are you seeing an increase in prior authorization denials? Does that limit the choices that you have in terms of your treatment choices and modalities? And then what can we do if it just so happens that we are diagnosed with cancer? What can we do to determine, to help us get the best available care regardless of the insurance decision on coverage?
That's a very good question, and you're right. Insurance companies, it's the thorn in our side as physicians, and unfortunately our profession has let that happen just over decades, right? We have put our head down and said, I only want to take care of patients, I only want to take care of patients, I only want to take care of patients, while behind our back, legislation and rules and laws and things are happening that we weren't sitting at the table. So we, as a profession, we kind of did this to ourselves. I have not seen, at least in my experience, 23 years of practicing medicine, someone with a cancer diagnosis not getting the care they needed for prior authorization. Okay? It's actually more common for just routine medications of chronic illnesses than it is for cancer treatment. Now, I'm not telling you it doesn't happen, and there's some cancer treatments that can be very expensive when you get into experimental stage. But just for routine evidence-based cancer treatment, it's covered. The problem is everybody will have a different option depending on the grade of that biopsy report they have. And so you will hear people saying, well, I have radiation, oh, I had my prostate removed, oh, I'm just under active surveillance, or I had hormonal therapy. But that's all dependent not on insurance. That's dependent on the grade and stage of what they have, and everybody's different. So not all prostate cancer is the same, which is why a lot of times you will hear different treatment. But for treatments that are proven to be evidence-based and that work, I have not seen someone not getting the care they need.
And on that same point, the thing is, you know, what I talk to my patients about, because we're able to do the primary care, we'll get that PSA, we'll do the exam. But the next step is, okay, I got to send you someplace else, a higher level, to get things done. And what they actually have to do is, okay, your engine gone in your car. You got two decisions. Get a new one, a new engine, or get a new car. How do you value your life? And we got to move you someplace else, because what's going on, it's not going to kill you today. You probably got 10, 12, at least. Go ahead, do what you do. But you will suffer. Take care of it now. Places, Meharry, General, there are places that will work with you to help you save your life and the quality of your life. What do you value? If you don't value taking care of yourself, then why are you trying to love somebody else? Why are you trying to take care of somebody that won't take care of you? It's the best love of all, is loving yourself and doing what's right. It starts there.
So Dr. Junior, I was about to comment on something that with the question more stated. Priorities. We've been talking about why we don't do this and why we do this. It comes out to sometimes with the effect, I mean, maybe y'all can help me with this. How do we get us to start prioritizing our health as our number one concern outside of the other things that sometimes we put in front of our health? What do we need to do? I mean, this panel, y'all have been great. And as they say, you're preaching to the church again. But how do we take this and reach out to those who are not here today and put them in a position where they start prioritizing their health as their number one concern?
You ask a good question. Why? All I can do is try to do my part. I'm the safety on the football team. I'm running against Marvin's team in North. Man, we gonna smoke y'all today, man. Maybe we did, maybe we didn't, but y'all,
It didn't.
whatever. We gotta go. Let's go.
So guys, I just want to say we really appreciate you coming out. You have a question?
Yes, sir.
Yes, let's do it.
Yes. Prevention is everything. Can this panel talk about nutritions, compounds that we can be doing proactively to prevent prostate cancer?
Yeah, I touched based on this in the presentation a little bit. We don't have a definitive medicine or treatment that prevents prostate cancer. But what we do know is that those who lead a healthier lifestyle, decrease weight, healthier diet, less alcohol, definitely nicotine products, they actually have a lower risk of getting prostate cancer. Not absolute, but lower risk. So healthy living is definitely a benefit for prevention, but we don't have one thing that we know can definitively prevent prostate cancer.
So nothing, no nutrients, vegetables.
Healthy living.
That we can do.
No.
A healthy diet, right?
Not your mama's
Fruits,
chitlins.
vegetables, fish consumption. Those are the things that are, when we say healthy diet as far as prostate cancer, what we're referring to. Going out to GNC or some nutritional store to get a supplement, you're wasting your money. That's not going to give you any added value than actually just eating a healthy diet.
What about ejaculation?
Yeah.
We got another question.
One second.
Okay, so, one of our panelists, has a prior engagement, and, you can still ask your question. I just want to make sure that we thank Mr. Marvin for sharing his story with us. Guys, will you please give him a round of applause? Mr. Marvin, we have something for you, sir.
You can open it up because you may have to share it.
No, you cannot open it up.
Oh, I know what this is.
My best friend.
Because it wasn't properly prepared in a gift bag. So, thank you, Mr. Marvin. We appreciate you taking out time on your Saturday morning to share with us. If you'll give the rest of the panelists time to answer one more question, then we have a basket where we're gonna have a drawing to some lucky person is gonna get a wealth of goodies in the basket. Thank you, Mr. Marvin.
One last thing. I'm willing to talk to anybody that wants to talk offline and quietly and privately. I'm always available. So, yeah.
Thank you for being here.
And so we have one last question.
One last question. Are there any studies or have you seen that men who ejaculate more often are less likely to develop prostate cancer?
Yes.
So
give us a second, guys.
excuse me. Yeah, so the question, I don't know if everybody could hear. So men who ejaculate more often, are they at decreased or increased risk? Decreased risk for prostate cancer. We do not know the answer to that. But what I can tell you is that frequent ejaculation can sometimes falsely raise your PSA. So remember I mentioned that the PSA was not a perfect test because it can be elevated for other reasons like enlarged prostate or infection of the prostate. Recurrent ejaculation or frequent ejaculation can sometimes falsely raise the PSA. So if I have a newlywed couple, a man coming in from a honeymoon trip, and then they're coming in to get their prostate checked, and it's high, that's going to trigger me to at least just, hey, you know, we might need to recheck this. Let's not jump the gun because typically we kind of know what happens on a honeymoon trip, right? So hopefully for his sake, yeah. But even in our everyday life, sometimes, you know, you may have a good week at home and being intimate and sexual with your spouse or your significant other, and then come in on Friday to have your PSA check and it may be high. We do have to take those things into account. So it can affect the PSA, but not necessarily prostate cancer risk. Very good question.
Okay. So I want to, yes, sir.
So is that once a year annual checkup with a PSA and a prostate exam? Is that still the standard today?
Yes, depending on the risk. Average risk between 50 and 69 once a year, shared decision making. But for high risk, as we talked about, just being a black man, you're higher risk. Starting at age 45 for high risk. If you have a first degree family history, we start at age 40. So the more risk you have, the earlier we start, but it is an annual once a year screening. And that is covered by insurance because it is a proven screening tool that once a year is covered by every insurance, from private to Medicare and any other insurance you have out there.
Okay.
Dr. Marr, would you define first degree?
Yeah.
So first degree is one person removed from you. So typically for prostate cancer, because it's diagnosed as we get older, it's a father, a brother, and obviously a child would be first degree too. So one person removed from you. A grandfather or uncle is two people removed from you. So that's knowledge that we want to know as physicians, but it's not considered first degree. First degree is one removed from you, and it only becomes a significant history if they've been diagnosed less than age 65. So if you have, just say, your dad and he's diagnosed with prostate cancer and he's 85 years old, that's family history, but we do know we see that more commonly as people age anyway, so it doesn't become as pertinent of a family history, but it is still one.
I got one question.
Yes.
And I know we got to wrap it up. It's next steps from this event right here. I'm assuming the next best steps is to consult with your physician and come up with a plan.
Thank you
We're about
for
to
sharing.
wrap it up, and Dr. Jackson?
All right. So yes, Dr. Lee.
Doctor,
And Dr. Junior, are you all taking patients? So I think, because some brothers don't speak up and, okay, I need to consult my physician. Do you have room on your panels to take patients? Is something that I think needs to be shared.
So personally, I'm fortunate to take care of a lot of people in this room, right? Which is a blessing to me. The unfortunate problem is it's only one of me, right? And let me just give you some stark numbers before I answer this question. So there's only 5% of black physicians in this country. And of that, only 2% are black men, right? 2% of all physicians across this country in all specialties are black men. So the numbers are almost impossible for every black man to have a black physician because we just don't have enough, right? Although there are studies like Dr. Reynolds Barnes mentions to show that racial concordance, people who look like us take better care of us, we still have to acknowledge, though, there are still many other people who are willing to take care of you. You just have to find the right one. With that being said, I do have a full panel, mainly just because, Dr. Julian, we're in demand, right? Because people want to see us, but it's only one of us. I still have to sleep at night. I still have to go home at night. I would love to take care of every single person, but unfortunately, being here for 23 years, my practice has grown to the point where we're busting at the seams. Which is part of the reason why getting young folks, as we all have organizations and community organizations that work with young people, steering them into medicine, because I'm going to need somebody to take care of me. And I won't have that, right? The way this is going right now, Dr. Julia and I might not be able to find a doctor, let alone a black doctor. So we have to encourage our youth to really get involved in science and STEM and medicine, and we can be the face to let them know that if they see it, they can be it. But the reality is we don't have the numbers, and that presents part of the problem.
And I do have a panel that's open, but I'm not always in Nashville. I'm in Matthew Walker, Clarksville 2 days a week. And I already have established patients, but I make room for patients who are new and want to be seen about particular things. You may see one of our nurse practitioners, or you may see one of my other physician colleagues, Dr. Kevin Dennis, great family practice physician. But we have to do things in tandem and things like that. Just like what was said, it ain't that many of us. And the thing is, shoot, I'm 64, and look, my foot ain't on. I got another 5. I know I'm gonna try, but at some point in time, you got to say I'm gonna live, because this. I got to do this and finishing notes. You know, you got to get this done. You got to get this done. You got to do this consult. You got to do this. And you know, Doc has said it. I got a life. But you know, the thing is, we can get that test and then discuss the test. And then if we got to do the exam to go along with the test, it's there. But the most important thing, what do you prioritize?
And I'm just going to share, it doesn't go unnoticed. Once you get the test, and I can only speak for our location, we have a patient-centered medical home department that ties up everything about getting you a referral to the correct person and a care coordinator that will follow it through. So it's a team approach. But the first thing is to get the test. Okay?
We're going to do a little housekeeping here. I know we're running late. We'll take one more question.
Just one statement. For those of you all who are in here, I was asked to make this announcement. Don't forget about our mobile unit outside. And there's opportunities to get some basic screening, blood pressure, things of that nature. And they're also running some other kinds of tests that help support some grants. So the audience here today, just don't forget about those opportunities outside.
And I want to just on that, you're more likely to die of hypertension, stroke, and heart disease. Prostate cancer is kind of nice. I'll give you a little grace.
All right, very good. We've had a drawing for those who didn't sign the registry outside. It's not too late, but it's too late to win the prize. We still need you to sign because we need the numbers and the contact information. So they arbitrarily made this drawing while we were talking, and there was number 10, and has to be our guy, T.C. Cope, has won the basket. He's outside, he takes care of Student of the Year for me today.
All right. So I would like to thank our panelists, Dr. Meyer, Dr. Reynolds Barnes, Dr. Keith Jr. From the bottom of my heart, I thank you.
And nothing else, Dr. Jackson, before you leave, this was not done just arbitrarily. It was made possible by our AIM Foundation.
Yes.
Brother Darnell, Brother Ken Woodard, Brother Sean Baker, can y'all stand for us? In order to keep this type of thing going in our community, we want to make sure you make donations to aimtn.org. All right?
All right. Yeah, I know once you go down this road to thank people, you always may forget somebody, but this is a team effort. We work with Shanika. Shatika had to go, evidently. But let's give the whole Eddie Walker, Dr. Jackson, let's give them a hand because they are the engine that keep this thing going. They call us up, hey y'all, we want to do it again. Like, man, do we want to do it again? Yeah, we want to do it again. So thanks for the support. We have lunch downstairs. It's Chick-fil-A. You know, it's a sandwich. And like, you can even have two of them because some people had to go. So with that said, what's the next step?
So you'll be getting an evaluation.